we get started, I'm going to go ahead and make an announcement because if I wait till the end, I may forget, and that is for anyone wanting to make public comments on the amended 07 budget only. We are having a public hearing on Monday, the 29th at 2 o'clock. There's a sign-up sheet in the appropriations office, the front desk. The cutoff on that's going to be 10 o'clock Monday to sign up. And if we have interest in having a public hearing, if people want to speak on it, we're going to have it Monday. If not, then it'll be canceled. So check the sheet before you come over at 2 o'clock. With that, we're just going to go ahead and get started. And Commissioner, the floor is yours.
Good afternoon, and I understand I'm here to talk about the 07 supplemental. I believe we have several items in the 07 supplemental, and we can just start in any process you want to do, Chairman. How would you like to proceed?
The best way to do this is let's go ahead and start in order with how the governor had his budget outlined with adult addictive disease services, and then we'll just follow it as through the changes. And just basically give us an explanation about the changes you've got outlined in your budget, what it's going to be used for, kind of educate us on the needs.
Okay. Well, we'll start off with the first change, which is the $9 million that are providing state funds to meet projected expenditures in our state hospitals. I want to speak to the issues related to that. Historically, and last we met, I talked historically about the funding in our state hospitals. Back in 2000, revenue maximization removed about $37 million out of our budget. During that time, the anticipation was that we would be able to bill Medicaid, and that the billings from Medicaid would replace and perhaps enhance that $37 million that was removed from the budget. In no year have we had revenues that would completely replace the $37 million. And during the course of the last 5 or 6 years, we've seen increasing use of the state hospitals by forensics. We have seen increased costs in the state hospitals. And as a result of that, we have had a historic deficit. When I came to DHR in 2004, the deficit was running at about $32 million and was being balanced each year at the end of the fiscal year. And that balancing was usually taking place by balancing in the community services budget. We took this to the governor and explained to him that in order for us to move forward and build both a community system and the hospital system, that we would have to deal with that deficit. Gwen Skinner and her staff worked with the hospitals to create efficiencies, to really get those budgets in shape. Historically, the hospitals had not lived within their set budget. But we found there were about $9 million worth of expenses that really can be attributed to lots of increases in the cost of medication, increases in the costs of special therapies that we have to provide. There's been a 30% increase in utility costs since state fiscal year 01 at the hospitals. There's been this increased demand for forensic services, which is a completely state-funded service. And so all of that has resulted in $9 million of a deficit that we believe if we were to continue to cut in the budget and create more efficiencies, we'd stop cutting fat and start cutting muscle. And so we are asking for $9 million to fill in the deficit that is an ongoing deficit that's attributable back to the 2000 year when revenue maximization removed dollars from our budget line. I'm not sure I'm asking Gwen if she thinks there's some other explanations that I can put with that, but that's in essence what that line item is for. And we'll be pleased to talk and hope we'll be able to talk as we go forward about the issues that present themselves in are trying to balance the service load that we have in the mental health area so that we have adequate community services as well as adequate hospital services. The second item,
Well, if you could,
you want me to stop at each one?
just pause just for a moment. I think how I like to do this today, because we're just dealing with a few items that we could go ahead and take questions on each section. That way we can kind of keep the train of thought the same as we move along. I guess I'm going to let the members go first, and I'd like to ask some questions also.
Yes, ma'am.
You said that the forensic beds were paid for only out-of-state funds.
Yes, ma'am.
Is that ordinarily the way those beds are treated? And if so, why?
It is ordinarily how they're treated, and I'll let Gwen talk about why.
We simply, when people are in a hospital or in an institution like a correctional institution, because it's a confined facility, Medicaid does not reimburse any of the cost for those. And so forensic consumers in our state hospitals are all state dollars.
Well, do these forensic folks make up this $9 million deficit that we're talking about?
No.
We're replacing some of the mental health beds that were in the state hospitals now with forensic patients rather than the other way around.
Yes, we are. The forensic population is our growing population. Because we have to respond to the courts and provide that service as that population grows and we run out of forensic beds, they are in fact being served on adult mental health beds. But we cannot draw down Medicaid dollars for a forensic consumer.
Next question comes from Representative Reese.
Thank you, Commissioner. Did y'all define, and I think you probably just did, and I'm new to this committee and
Yes, sir.
not shy about forensic beds. Could you define that? And
Yeah.
also, too, do y'all have the same document we do? So when we're talking about a line issue, can you tell us where we're at?
This is the document I have, which is the governor's published version, and I'm not sure what you have, if it's the same thing or not. Okay, apparently now I'll have it. Oh, that's okay. Forensic, by definition, refers to two populations: people who are found incompetent to stand trial when they go to court, and people who are found not guilty by reason of insanity. And so confinement in a mental health facility is what happens with them in order to either until they get competent or are found to be competent, in which case then we send them back to the court.
Is that all?
Thank you very much.
You're welcome.
All right, we have a question. Speak a little bit closer to the mic. Next question comes from Representative Carter.
I just want to follow up on the forensic beds and the definition of it. Now, these are beds, where are they located?
In the state mental health hospitals.
And I'm assuming that because they are offenders, that they have to be specially guarded
Yes.
or something? So,
Yes, and I can let Gwen talk a little bit more about it, but they're special security and they are in a special unit by themselves. In other words, typically they are not mixed in with the main population. I will be honest and say at times when all of our forensic beds are full, if there's someone like Etna the bag lady who consistently gets arrested, brought to court, found incompetent to stand trial, we might put her in a regular mental health bed because there are no more forensic beds that we're already full. But anyone who is a serious offender is in a secured unit on the hospital grounds that is designed to house forensic consumers and has appropriate security related to that.
Any other questions from the committee? Commissioner, I had a question. The $9 million that we're asking for, basically to, in other words, play catch up, so to say.
Yes.
Do you believe that these deficits over the last few years in our mental hospitals, do you think they directly have contributed to some of the things that we're reading in the paper now with some of the patient safety issues?
Let me say this to you, with all due respect to the newspaper. The characterization of the deaths in the hospital that we have had, that the newspaper is reporting about, go back to 2002. Most of the highlighted cases that have been in the newspaper have been cases that go back to 2002 or 2003. Indeed, in the last few years in the hospital, we have seen fewer people dying in our state mental hospitals than, so this is a number that's going down, not going up. On national measures related to safety and security in hospitals, we are either at the national standard or we beat the national standard on most things. The only thing we do not beat the national standards on or are at national standards on is readmissions to hospitals. The problem with the readmissions is we have high rate of readmissions because we have not adequately built the community services that would allow people, once they leave the hospital, to be able to stay at home near their families and in the community. And so when they decompensate again and have another crisis, the only door we have for them is the hospital door, and that's where they wind up. The issue of deaths in the hospital, we follow a number of different regulations and a number of different oversight over how we deal with those deaths and how those deaths are looked at and reviewed. I would not agree that we have had 115 suspicious deaths over the last 5 or 6 years in the hospital. And I don't believe that the dollars that you see either in the 07 supplemental or even for that matter the ongoing deficit is in any way related to the articles. However, I do think that we have some financial issues that we need to solve, which would allow us to both run a good hospital system as well as build the community services that we need to build. This goes on, this continues to be the challenge. So the filling our deficit is to make us whole so that we will have adequate resources on both sides of this pendulum, so to speak. Enough to build the community and enough to run the hospital. When you ask me how I take the newspaper articles, I take newspaper articles as an opportunity to ask questions of ourselves, and we do, and an opportunity to check and make sure that if we have procedures in place, are we following them? And my check on that is that we are. One could argue, are they enough? That I think should be discussed and talked about, and reasonable people will have different opinions about it. But in no way do I believe that the numbers they reflect are accurate. I would not agree with their conclusions. However, I take their feedback and their insight in, and I think we should carefully take a look at whatever we're doing. One particular case in the newspaper, Sarah Kreider, 14 years old. The day that I heard Sarah Kreider died in the hospital, I immediately put together a group of doctors who were not in any way affiliated with the mental health system. And I sent them into that hospital and I asked them to investigate. And I asked them to bring me a report, and the report they brought me said that they felt that the attending doctor who had been caring for Sarah Kreider those weeks that she had been in the hospital and medicating her was responsible in their mind for what had happened with her. We immediately began termination proceedings for that doctor, and we did discipline for the resident who was on duty with him at that time. We recently heard from the administrative hearings unit, what is it, Administrative
hearing.
It was administrative hearing was held. The doctors that I had come in to take a look at what happened testified, and that hearing upheld our termination. That I felt was an incident that we did not believe should have ended in the way it did, and we took measures to deal with it, and also are taking measures to follow the other recommendations that those doctors gave us about what we should do. So that's a long answer, Chairman, to really say that this issue of money may be related to the issue of operating hospitals and operating the services we do, and we're trying to balance that out, but in no way would I associate that with the series of articles that the AJC has run.
This next question, either you can answer or Deputy Commissioner Skinner can answer. I'd kind of like to expound on those recommendations. What are we doing to improve the situation in our mental hospitals? What steps are we taking to make sure we don't have another one of these incidents? And also, if you could follow up, or you can start with, I'd like to expound a little bit more on what these deficits have affected as far as your services in the hospital. I mean, I think the whole committee would like to kind of have an idea of, because of this deficit, I mean, what has been affected.
The improvements in our hospitals, I think one of the more significant things we've done is partnered with the Medical College of Georgia, who are going to be coming into every one of our hospitals and looking at the clinical services that are provided, both medical and psychiatric, to the people who are in the hospitals, and give us a good read on whether we're remaining current, whether the services that we're providing are best practice. We certainly have gone back over every policy that we have related to the reporting of special incidents, when that's done. Is there a smooth process between ourselves and other people who should be receiving these reports? We investigate special incidents at the division level, because everything doesn't rise to a death, is that we investigate these at the division level. We investigate these at the DHR level with our Office of Regulatory Services. So we're working with them to make sure that process is current, that the communication is what it should be. We also have worked very closely with the Georgia Bureau of Investigations and are looking at what our process is, and are we reporting everything that we should be to them, because they investigate deaths also at our hospitals when we think there may have been a crime committed, or anytime there's a crime. So every level where we have reviews, we're going through to make sure that we're doing what we should be, that we're reporting when we should be, and then we're bringing in the Medical College of Georgia to look at what we're doing. We also have, Commissioner Walker's reminding me, is we have a process, root cause analysis, that your physicians go through when there is a death or when there's a serious incident. And what they do is dissect whatever happened to make sure what was the cause of that, and is it a problem, is it a single incident, or is it something that may be a pervasive problem in that hospital or throughout the rest of the hospital system, and then we're using that to determine what type of quality improvement that we need to do throughout the hospital system.
Yeah, well, let me say
Yeah,
that.
you say that.
We also are, one of our ongoing issues is maintaining and sustaining staff. This is a difficult job. We have human service technicians. It's one of the highest turnover positions we have at DHR. And then we have nurses at the hospital. Again, one of the highest turnovers that we have in terms of personnel at DHR. One of the things the governor's budget is allowing us an opportunity to do this year is to look at raises for nurses in particular that would allow us to get more competitive. We won't get as competitive as the private market, but we can get more competitive. And quite frankly, most of the people who work in a mental health hospital are not there just for the money, but when the money difference gets too big, it's a matter of their own family's welfare. So we're going to be looking at what can we do for nurses' salaries, incentive bonuses for retention, those kinds of things. We're also looking at that for the human service technicians. What creative ways can we use the budget we have to begin to retain HSTs, again, with retention bonuses, with Gwen and I talked the other day about having more than one level of human service technician, because if there's only one level, you don't see any room for advancement. And so these are some of our lowest paid, and this is not a high job in terms of your educational necessities. You don't have to have a high educational level. And so what can we do to incentivize them to see a ladder of promotion for themselves within the system? So those are some of the things that we're doing to address the issues within the context of the hospital and to address what's going on. But I think first and foremost, the thing we need to do is to get it so that people find that the hospital is their last resort, not their first resort. So we've been increasing crisis stabilization services in the community. We are creating 23-hour observation units at all of our hospitals. What this means is if you stay in the hospital less than 24 hours, you're not admitted, and we have the ability to work with you, to stabilize you, to help you through a crisis in that first 23 hours and determine, do you need to come in the hospital? Sometimes people come in the hospital because it's the only thing there. So we're putting in place things that will help us keep people from coming into the hospital in the first place, rather than and thereby bringing down our utilization rate in the hospital. Our utilization rate is running about 109% right now of utilization. We'd like it somewhere in the high 80s, just under 90% would be more optimum. And so the only way to do that is try to keep people who don't need to be in the hospital from using the hospital as the only way to get the services they need. So this is a wide spectrum of changes and things that we're looking at to strengthen how we run the hospital system, but how we run the mental health system first and foremost, because only balanced system will really work best. And right now we have an out-of-balance system with the hospital being overutilized and not enough community services. This $9 million will assure us that we don't, that we have enough to run both systems well.
Did you want to speak about the things that the deficit has affected in the past few years, the things that we've been doing without the hospital?
Sure, and I think that the commissioner did a good job with the nursing. The one thing that I would add to what she said is possibly what people don't understand is that in our hospitals, when we're not able to recruit and retain nurses and human service technicians, what that means is you have to go out and you have to contract for those services. And so you have nurses who come into your hospital who work a shift and go home. They don't have a relationship with the people who are in there. Many times when you're talking about people with mental illness and developmental disabilities, communication is a difficulty for them. So if you have nurses who come in and just work a shift, don't know the people that they're working with, communication is difficult. It presents, they can't tell you when that things like they have not gone to the restroom in 3 days or those type things if you don't have communication. So it's very critical for us that we have the money to keep nurses that have relationships with our patients in our hospitals. The other thing that we give up is medication. We know that when people leave our hospitals that they need a certain amount of medication to go with them, whether that's for a physical illness or whether that's for a mental illness, and that we need to give them a certain amount of that. And so if you don't have adequate money, you trim that back as far as you can and give them what they absolutely have to have, try to make sure that they get a follow-up appointment in the community, and then try to make sure that they get there for that appointment. So medication is a big issue. We give up the frequency with which you can give people the therapies that they need. Speech therapy, things that have to do with communication. The physical therapies, particularly that the developmentally disabled consumers need. Activity therapies, just services like dental services. When you talk about half of your hospital population being people with developmental disabilities, they don't historically have good dental care. Without good dental care, their health consequences for that can be very expensive. So giving up those kind of therapies for them. And we even have to look at what the diet is in hospitals and make decisions about food and what you serve people. And for people who have to live in an institution, sometimes food is one of the bright parts of their day, and we like to make good decisions about the diet that we provide there. So those are the type of things that we have to give up when we don't have adequate money.
We have a question from Representative Reese.
Mr. Chairman, y'all were talking about getting people to use outpatient versus being hospital being admitted to hospital. Are you referring to the long-term drug rehab centers for youth, for adolescents in Georgia? We're starting to hear a lot about centers being shut down and then using outpatient services, which I don't agree on that.
And I'll start talking, and I'll let Gwen sort of round out some of the details. The problem that presents itself to us for solution is that the dollars we have had historically for substance abuse treatment for children and adolescents has been all spent on inpatient residential services. Given that we can only serve about 175 to 200 kids a year. And when those kids get out of the residential treatment service, we don't have not one dime in the community itself for outpatient. All of us know, and it's no different for young people than it is for older people. Addiction is a disease where you go into recovery. But when you're in recovery as an adolescent and you return to your high school and your community and your friends, if we don't have you in an outpatient program or have outpatient services available for you, you're going to go back the route, a lot of times, of drug use. And so we wanted to create a balanced system out there so that we would have enough services in the community so that kids coming out of these programs would have some place to go. In addition, what happens now is your child has to be really strung out, if you'll pardon my language, for them to get in a residential program because we have so few slots. And so all those kids who are first experimenting with beer and marijuana and all the drugs we don't want kids to use, we have no programs for them either. And so rather than catching them on the front end before they become addicted, we're actually all at the deep end pulling them out of the water, but we don't have enough resources to pull them all out. And even if we get them out and clean them up, we don't have any place for them to go when they go back home. So what we're doing is really divvying the money up to continue to have residential beds in the state. And those residential beds, we will have shorter terms of stay, because right now kids are staying 10 months, 12 months, 18 months in the residential program. And really the more... Absolutely, and there may be an occasional child who might need that, but it certainly shouldn't be typical. And I think what happens is it's just like in any good program. You bring in a kid, you turn them around, you get invested in them, you care about them, you keep them. You want to keep them away from the bad things that are out there back in their communities when they get home. But what we want to do is we'll be able to serve about 1,400 kids Some who will be in outpatient and some who will still use inpatient will still use inpatient, and we'll still be able to serve about 150 kids a year in inpatient slots by the model we've put in place. Now, I'm not sure if I've said everything. Yeah, and so it's a matter of balance again, not having everything at the deep end and nothing at the shallow end, and so everybody has to float to the deep end and be addicted before we can get to them. We want to get them while parents are still thinking, I can handle this if you just give me some help, but we don't have any help.
I got a lot more questions on that, and I'll take it forward. Well, but if we don't get them dried out, then what good would outpatient?
Well, we will be getting them dried out, but inpatient. We'll still be able to serve about 150 kids in inpatient, but instead of them saying 10 months or 15 months, they may stay 4 months. Clinically. I'll let the clinician speak.
No, it's actually a matter of utilization review. That's part of the problem, is we haven't had that in place before, and so children were typically placed in substance abuse programs by agencies, sometimes by families also. Now it's going to be a process of utilization review where you look at the needs of the child, the progress of the child, and they're going to move through the system more quickly. We did a lot of research on this because we knew that it was going to be a dramatic change in Georgia. We actually brought in the Center for Substance Abuse Treatment out of SAMHSA. We brought them here to Georgia to look at our data, to look at what resources we had in place. They told us part of what we already knew is that the earlier that children are using drugs, the longer they're going to use drugs. And so we needed to back our services up and start touching children often and earlier. And so we looked at models to do that. We then went to Johns Hopkins, and they said you need to have shorter lengths of stay in residential care, and you need to spend more of your money on supportive services to families and children in the community. So they thought we were right on target and gave us that recommendation. And then we've also just looked at every publication, and everything that we're reading on children says that you need a shorter length of stay in residential and longer on your aftercare services. Also, detox, and I understand very well the concerns about detox for children. One of the reasons that we have such a big push on, and you see us continuing to come to the legislature saying, let us have money for more crisis stabilization programs for children, they also are capable of doing detox. So those will supplement these 3 to 4 month beds. You'll see more, you can do the detox in the crisis stabilization programs too.
Yeah, I totally agree. I mean, if the child's staying 10 months, you should only be there 3 months. But I mean, you know, you tell me who makes the decision, but why don't they make that so these houses can stay open and help 3 kids instead of 1 kid? See what I'm saying?
Because without making the shift, because number one, we will not need, with the funds that we are setting aside for residential services, you right now are spending about $4.9 million to run 142 beds, and kids are staying there 9 to 12 months. I can take $2.5 million. I can run 32 beds where children can stay there 3 to 6 months and still serve 150 children, because they're not going to stay there as long.
Yeah, I'm not debating that point at all. I mean, to me, if somebody stays longer than they should, it's like going to the hospital and have to finish.
Sure.
Staying 3 months. Because they got this food.
Yeah.
Yeah. You shouldn't have some of the adolescent programs. So those kids that's either in there now are going to be out, pushed out back into the community where they're going to trigger whatever causes addiction anyway. I don't see how it's helping. And I would love to try to get you more money to keep those open too. And run it better where they stay 3 months instead of 9 or 10 or 12 months. You keep saying that, but who makes that decision?
It's clinicians, when they call to request.
Work for y'all.
No, we have external utilization review, and we have, but yes, they're under contract with us to make that decision. But then they also, even in the 3 to 4 month program, if you have a child there that clinically needs to stay there longer, there's also a process to request that exception. So it's not like at the end of 4 months, if they're not ready to go and you know clinically they are not ready to go, then nobody is going to open the door and shove them out. It's just we know that the longer lengths of stay are not increasing the outcomes for the children that we're serving.
I've done that.
Yeah.
And that's what professionals make that decision. But what's going to happen to kids when you shut down in March? That's in there now.
Those children, there is a certain point in time where we have worked with the providers of those services, asked them not to accept any more children because we wouldn't want to prematurely bring them out of treatment, and then we work on them on developing the discharge plan and putting the resources in place for them in the community. So it's a child by child, working with them and their family for that return.
To follow up his question, when did the notification process start with these centers? 'Cause I know that's always a concern, because a lot of times we hear different stories about we just found out, whatnot. What kind of lead time have you given these different facilities about the change that you're trying to institute?
They received their first notification on July 21st because we knew that they were going to need time to make the transition and to work with families.
Stay here a minute, just in case.
Ms. Commissioner.
Yes, ma'am.
What concerns me about this, I understand the process and I understand how you want to give kids shorter stay and get them back in communities and all that kind of stuff is. But I'm concerned that the number of beds that we are shrinking to, the 32 number, is just too few too soon. And one of the things that really concerns me is that if the kids that are going to be falling out of this category are going to end up in our juvenile justice system and are going to end up in jail, and actually there's substance abuse or something like that, and they really don't belong in jail. And 32 for the entire state of Georgia, I'm from Cobb County, and I've worked at defects a long time, as you well know, and I could probably go through the list of workers at defects that I know with their caseloads and fill all 32 beds out of Cobb County alone. And it really concerns me that we're making this step and we're going to have an article in the paper or whatever because we've made this step. Are you at all concerned about this?
Concern is, I'm concerned. Yes, ma'am, all the time. And I've asked Gwen and her staff to carefully evaluate what they believe our capacity needs to be. The one thing that we know has to be there is the money for kids in the community. I was in Statesboro, that's where I was, Statesboro, and I talked with a number of the kids and the providers in Statesboro when I was there. And one young lady said to me, well, I can't go home. I don't want to go home. I'm not going to be able to be, I don't like home. I don't want to be at home. And so I asked her, I said, how old are you? She said, 15. I said, one day you've got to go home. And when you get there, I need to be there with some money to help you to make that transition, because I can't keep you at this facility until you turn 18. And so that's, if you ask me, am I concerned when we have to create a balance of resources to get the full spectrum of services? Absolutely. I mean, that happens not just in this program. It's what we're doing with the hospitals and community services. It's what we do every day with almost every service. I believe that Gwen and her staff have made a very, very careful and thoughtful and rigorous analysis of what they think we need. One of the reasons we did the notification back in July was to not find ourselves in a situation where we had children who had just come into that. We're going to be shifting dollars as we go to get money in the community for every child that goes back. So that's the first shift. And then as we bring children in, we'll assess that as we go. If you would ask me, what might happen? A year from now, when I go to the governor with my budget request, I may say to him, here's our history of moving this program out and getting a balance of services, Governor. But here's what I need to make it be what it would be. So you would fully expect, and you will see me in that budget process asking for additional dollars if I find that what we need to do is ratchet back up. But I believe, and I've looked at the numbers and I've looked at their work, and I think they've done good work to assess what we could do. But we're always going to be concerned, and we're always going to be looking at it and evaluating it.
As a real quick follow-up on
Yes,
that,
sir.
Then Representative Carter will be next. Do we have a plan in place? I mean, I also am very concerned about the 32-bed number. Because obviously the biggest concern is these children that we're treating. I mean, I had 2 young girls in my office the other day, and I told my aide when they left, I almost had to go get a box of tissues from both of them so she could get out of there.
Yes.
What's the plan in place, just like Representative Manning said, when we do fill up those 32 beds? What if we have 10 more individuals, boys or girls, that need a long-term care program? Where will they go? Or do they just...
Well, at the same time, and I think when Gwen was speaking to this, and I'll start and let her finish, one of the things we can do almost immediately when that happens is utilize the crisis stabilization beds that we are putting in place all around the state. That is short-term beds for kids who are having an immediate crisis and need to get into a program.
Where would those be?
Well, they're going to be one in each region. Right now, we are working with, there's one up now in Savannah. There's going to be another one just recently came up in Columbus, and we're working on 3 additional ones that'll be up by the end of this fiscal year. So we will have them in every region of the state, and those will be beds where kids in immediate crisis, no matter what the nature of the crisis is, will be able to go there, and then we'll be able to work and get them moved into another program. Now, this happens though now, and so I want to be clear that there are kids now who need the service, and we have to work and do and juggle and work with parents and figure out what happens, and sometimes they have to wait for the service. That's the nature of substance abuse services in general. They're never enough when you need them, and sometimes you look around and you don't need them and there's some openings, so it's not something you can control the flow. But even right now, sometimes that happens.
Okay, well, I guess that's where I'm staying a little bit confused. We want to drop back to 32 beds, but now you're saying that currently we do have a waiting list now. We've got kids placed in these, basically, I guess, for lack of a different term.
We don't run a waiting list on them. I'm saying that there are parents calling or people who think my child needs substance abuse treatment. Right. And so when we...
You don't know if they're the ones that need a long-term, or you can do a community-based?
Right. We don't have any community-based, so if they need the service, we have nothing to offer them in the community, which is part of the problem. If you call me in this new scenario, I'll be able to say, here's the number for our nearest outpatient substance abuse program, because that's what happens with adults now. If I were to become addicted to alcohol, and I showed up and needed residential treatment, and there were no residential beds open, they would assign me to an outpatient program while I wait for a residential bed if they think I need a residential bed. But we don't have outpatient substance abuse treatment right now, and so any child who needs a service only has one type of service to go to.
Well, you said something in that statement right there that I definitely have to follow up. I hate to keep putting other members off here, but we need to try to stay on the same train of thought. You said currently we do not have any community-based service, but yet we're planning on switching to this in March. I mean,
Is March the date?
Are we going to have something in place?
Yes.
Okay, well, you need to
I mean,
explain that.
For example, if somebody's down in Cooler, Georgia, and they need a community-based service, where are they going to go? Or anywhere else? I mean, I guess what it comes back to, I have a concern. I mean, there's one term right now that when I first heard it, it sounded really good, and it was all fuzzy, and that was community-based service. And every time I heard that, oh, that sounds great, community. You know, community always sounds good. I always refer to community a lot when I'm giving my speeches. However, the longer we go, the less I'm liking the term. Mainly because the fact is, I'm not sure what it means. What is community-based service? I mean, the way I kind of think of things, from now on, I don't think I even want to hear it again. I just want to hear, okay, we're going from this service to this service. It's kind of like one of those, you know, a date to be determined later type situation. That's what I thought we're dealing with. It's a service to be determined later. And I think everybody on the committee is concerned. I mean, it's not so much that we want to preserve any one certain way of doing things. We want to do the right thing, and we want to make sure there is something there. And when we just use the term community-based service, I think that gives everybody, I think at first it's kind of warm and fuzzy, but then when you get to thinking about, well, in my community, I don't have anything. What's going to be the service in my community for these kids?
Part of the transition has been to work with our community service boards and other providers in transitioning, if they're going to provide services to children in Georgia's communities, that they need to be using a best practice. The model that we worked with for the Centers on Substance Abuse and talked to Johns Hopkins is called 7 Challenges. It's one of the most effective models in working with children. And that is the one that we've adopted. We have worked with the CSBs and other providers to provide that training to them free. And we started that, too, back in the fall so that there would be some consistency. Because also what we know about Georgia is that if you move from one place to another, that what you can get is very different. And if you're going to work with children, they need some consistency in the treatment model. So we're trying to do that, too. So we are very thoughtful. It's not just saying that children are going to be served in the community. We have given them the model that we want used with the children. We've provided the training to them so that they will have people who are equipped to do it. We've said that there are certain credentials for people who should be providing this, that not everybody is well suited to work with adolescents. And so we have been very structured in what we want and very prescriptive in what we want for Georgia's children. The crisis stabilization programs, basically right now what you had these 150 to 200 children who were going into a very limited number of beds in Georgia, and that's where the bulk of our money was going. And so what we're doing now is saying, okay, here's the outpatient. We want you to use 7 challenges. It is an established best practice. Use this model. Here's the training. Here's the staffing that you need. We ask for money to do crisis stabilization and bring that up in Georgia. That's been new for Georgia over the last 2 years. They can serve the purpose of detox, because a lot of kids and a lot of the drugs that they use, it's an issue of detox, not necessarily long-term treatment. If you can get them off the drugs, they can be at home with their family and in outpatient treatment. And so we've put crisis stabilization in place, and then we're saying with the 32 beds we can serve practically the same number of children in residential treatment that we're serving now for a longer term for those children that need longer term. So we've basically got a 3-stage process now where there's the 7 challenges community-based, there's crisis stabilization for detox, there's the 32 beds for the children who need it longer term, and then when they're through with that, they can cycle right back into the 7 challenges program that they should be familiar with and their family should be familiar with. So it's a building process.
Representative Carter, you have a question?
Just real quickly, can you tell me about your success rates and about your reoccurrences?
In terms
In
of
terms of the children who come through, I mean, how many of them do you see back in 6 months? Are you still following them? And if you are still following them, how are they doing?
I would say that each of the individual programs, those are typically provided by the community service boards, and I can certainly get that for you for each of those programs. We know that the nature of addictive diseases is that you have it's a disease of relapse. Children are no different than adults. They go into recovery and they relapse and they come through treatment. You have only to look at our juvenile detention centers and see the population there for drug-related offenses to know that they are relapsing. I can get you the specific data for each of the programs.
Well, I think it would be useful. I think any time we approve a program like this, I think we need to know the results of it and know whether we need to do more or do something different or whatever. So I think that would be very, very good for all of us.
Well, we'll provide.
Be happy to do that.
And if I can really throw a curve here, can I go back to something I'm trying to let go of, but I can't. You gave an answer a little while ago on a different subject. Someone asked you about $9 million, and if we didn't get that, what would we have to do? And I'm not disputing your answer. Please understand that. But you mentioned about the continuity of nurses and how important that is in facilities. I agree with you. But you also gave an example, I think, of a patient who might have trouble with urination after 3 days. But we do have 24-hour nursing notes, and they do communicate between nurses, whether it's an agency nurse or whether it's a routine nurse. So I just didn't want other members of the panel to think that. I just think that's a reach to give that kind of example.
No, I absolutely agree with you, but I also know from looking at those records and reviewing those records is that communication is much better when the same shift of nurses is seeing the same shift on a day-to-day basis, and they know the same consumers, know if they were talkative on one shift, and they can communicate. It's that kind of information that we lose when when we rely heavily on contracted nurses.
I agree with you 100%. But again, I'm not trying to dispute what you said. I just want to make sure everybody got the right idea.
Okay.
Representative May.
Thank you, Mr. Chairman. Commissioner Moore, you said that we have 32 beds, or currently the state provides funding for 32 beds. It's not that there aren't more than that available throughout the state for this type of program. Is that correct?
No, currently we have about 142 beds, and we're moving to a model with 32 inpatient beds, but a lot more outpatient services.
Have we, or do we, and you have to excuse me, I'm like Representative Reese, I'm rather new at this process, and I'm trying to understand
Sure.
how everything flows and works. Have we contacted, or do we have any programs that deal with the private sector that would allow, private funding, or from corporations or whomever may have an interest? For instance, we talked about community-based service. When I hear that, I'm thinking something that's local to a specific area. And some of the houses are being closed down, like the Ronald McDonald House, for instance, or something like that. Is there? Have we done anything? Have we contacted anybody? Has anyone tried to contact the state or DHR to try to offer or help in this situation? I know, 50 years or 100 years ago, if we had a problem, we didn't go to the state or a state agency or the government for help. We went to our families and our churches and our communities to get outreach and to get help. Is there anything now that we're currently doing that would follow along with that? Or?
Well, we do a number across DHR. There are a number of services and volunteerism and community who's come together and families who come together to help on a multitude of family problems that we see. Substance abuse.
It's very difficult, very challenging.
That's right.
With methamphetamine and the
That's
problems
right.
we have today. It's a completely different dynamic than we had 20, 30, 40 years ago. It's new to all of us.
Mm-hmm.
But I would think that we would have people who would be trying to reach out and help in some way.
Well, we do for many, many issues. I'm not aware of a lot in this area, but certainly we are always open to it, and we're always seeking it. And however we deliver any of our programs, we try to work with local communities or churches or whomever to try to follow up. I've seen a lot of good 12-step programs for adults, for example, affiliated with churches. And that would be very helpful because that's good outpatient work that doesn't have to be funded by a government dollar necessarily. So it's our intent to do that kind of thing as much as we can, but we just haven't had a lot in this particular area offered.
Well, Commissioner, I think we've definitely got a lot of questions probably still
Okay,
in this
sure.
area. It's often obviously going to be a big concern to this committee. And we'll work with you and go forward. And I'm sure you'll be available for additional questions.
Yes, sir.
But right now, I know time is of the essence, and we're going to move on to the next subject, which I believe is going to be on page 61, your next budget request change, which is the funding for the antiviral medications.
Yes, so we're requesting $15 million plus to provide funding for antiviral medications to treat pandemic flu should it become an issue in Georgia. I'm going to ask Dr. Brown, as the science expert in this, to really come forward and provide you with a good, strong background in what this means.
Thanks for the opportunity to be here and to talk about this. If you'll allow me, I'd like to give just a little background around the question of this request. Pandemic influenza is not the year-to-year influenza. It's infection with a virus that's distinctly different than the human beings have been exposed to in the past. And so nobody is immune. And when that happens, the transmission of the infection is passed from person to person and covers about 30% of the entire population. And the reason that we're concerned about pandemic influenza is that there is a fairly long history of pandemic influenza outbreaks occurring over the centuries, really. And they've averaged about one every 30 years, but they're not at all predictable. The other reason for our concern about pandemic influenza at this point in time is because of the avian pandemic that's occurring now throughout Asia, Europe, and Africa. That's been a pandemic that has been affecting primarily wildfowl and domestic fowl, and has continued to be a problem over the last 5 years. And the further thing that's problematic about that strain is that when a human being gets infected because they have close proximity to those flocks of chickens or ducks, the mortality rate has been more than 50%. So it looks like if this were to become transmitted person to person easily, it would be a very serious problem. If, for example, a pandemic were to occur in this country, and these are the guesstimates that the world's experts are putting around the question of pandemic influenza. If 30% of the population gets infected, in Georgia, that would mean that about 1.5 million Georgians would need some kind of health care, that about 300,000 of those would need hospitalization, and that there would be approximately 60,000 deaths. Now, we're not just holding our breath and waiting for a pile of pills to be on the shelf. We've been doing a lot of things over the last year and a half in particular that range the gamut from trying to get community-based planning around this issue to developing our surveillance system and our laboratory capacity and other issues. The recommendation for antiviral treatments has come from the Centers for Disease Control, the National Institutes of Health, and the World Health Organization, and international flu experts. There's fairly good evidence that the antivirals make a difference in both the severity of the illness and of the shedding of virus from that individual. This program has been strongly supported by the federal government. So the federal government has already purchased and has in stockpile enough treatment for 1.3 million Georgians. Who would become, which is the number that, part of the number that are projected to get seriously ill. The other part, they're asking for states to come up and get some additional, in order to meet the projected needs for the severely ill. And in Georgia's estimate, that is 2.2 million individuals. And so we're asking in this supplement a one-time allotment of $15 million to purchase that additional 900,000 treatment courses. CDC, unlike most of the federal programs that I've been associated with, they didn't just say, this is a good idea, go do it. They actually are also, they're not only providing the 1.3 million doses or courses, but they're also providing a match of 5 million for Georgia if we provide $15 million in purchase. 43, $5 million. Just by way of background, 43 states in total are making purchases of antivirals. They've indicated their interest in that. The 33 of them will take their full allotment, as we have indicated. I'll stop right there.
Our first question is from Representative Reese.
I was on the pandemic study committee this last year, and refresh my memory now, was that one of the recommendations from the study committee, was to go ahead and purchase these vaccines?
Yes, it was.
Okay, I thought that was right. And also, to refresh my memory, what's the shelf life of that?
It's at least 10 years. It's got a 10-year lifespan as projected now, and we know that the FDA will be working to see if they can extend that shelf life.
As I remember, it was not a matter of if it happened.
That's correct. I mean, the dilemma for someone in my position is there's a lot of ways that I'd like to spend $15 million, as I'm sure you all would. But it seems to me that it is we will be rightfully rebuked if we don't have that available, and in this next 10-year time period, we have a pandemic outbreak.
Next question is from Representative Carter.
Help me to understand this $5 million that the CDC is helping us with. So the $5 million, will that go along with the $15 million that you're asking for?
That's correct.
A total purchase of $20,714,000?
That's correct.
How many doses?
For 900,000 doses.
For 900,000 doses, which equates to what you said the federal government has for the state of Georgia.
The federal government will provide us 1.3 million and total people courses, and we're going to purchase 900,000 to bring it to 2.2 million.
Okay. And you answered one of my questions. The strain, the viral strain that you're speaking of, is the same. It doesn't change year to year as it does with the flu strain.
You've been exactly right in several things. First, we don't know when it's going to happen. And secondly, we don't know which strain it's going to be. I mean, we're worried now because this pandemic avian strain is so persistent and so lethal to humans. But we don't know whether it's going to take on that property that allows it to be readily passed from person to person. And so we don't know if this is going to be the pandemic strain.
So what I'm trying to get at here is that we're not going to be back here in 2 or 3 years saying we got a different strain, we got to have a different vaccine, we got to have 15 million.
Oh, no. The antiviral medications that are being proposed work as neuraminidase inhibitors, and so they will prevent they are effective against all varieties of the A versions of influenza, which are the ones that cause pandemics.
Okay, can you speak to the effectiveness, the efficacy of the drug?
Most of the work has been done in animal models. There is a little bit of assessment of the effectiveness against the current pandemic avian strain that's going on. And it does support the animal studies that show that it much improves the survival rate of infected lab animals, and it also decreases the virus load of those animals.
Okay, in worst case scenario, we do have an outbreak and we do have to use it. Will we, as the state, get reimbursed by private insurance if the patient has it, if it has to be used in a hospital setting? Is there any way we would know something like that?
We do not anticipate doing that at this time. And the reason that I say that is that our ability to do the normal sort of screening for where's your insurance card, let me double check and see if it's going, would have to be suspended if we were to have a pandemic outbreak. We would anticipate that something like 30 to 40% of the workforce everywhere will be missing. And if that occurs, we're going to be in dire straits, not only in the hospitals, but in the utilities and in the businesses and in the gasoline system and so forth. And so I am predicting that that will not be a feasible thing. We can certainly look at it. It's not something that has been on the planning horizon. It's not been part of the way that we've been thinking about it. But I'll take that back and make sure that we, yeah.
One last thing, if I can. The federal government is obviously involved in this, and they've made purchases of the vaccine. Is there some kind of buying group, some kind of bid process that the state took part in that we were able to get the lowest price?
No, actually, the federal government tried to do that.
Was that successful?
Apparently they were, yeah. Because
we piggybacked on them, we got the price.
That's right. And so we had to announce our intent to make this purchase. And so once we heard that the governor's budget had this, we had to hurry up and get our letter of intent in so that we could say, please reserve a portion of that you're buying for Georgia. We haven't made a commitment to buy it. That depends on your all's decision.
I guess I was remiss the other day, and when we did the rules, I forgot to read one rule that applied to the audience, and that's to turn off the cell phone. Or at least put them on maybe we'll take time the next meeting, we'll start off and read that rule. Next question comes from Representative May.
Thank you, Mr. Chairman. I'm not a doctor or a pharmacist, so just help me understand this.
Right.
You said that we have fairly good evidence that this particular vaccine or drug will cure the problem. What do you mean by fairly good evidence?
What I mean is that the animal models in a number of different facilities have been tested against this particular strain, and they have been effective. whether they're in laboratories in Switzerland or laboratories in the National Institutes of Health or wherever they are. And so it's not like one guy out in such and such a place found that it seemed to be working, but a number of investigators have identified.
How often and how significantly does the virus change?
Oh, it changes continuously. I mean, the change, the mutation of the virus is really the reason why I can't answer the question of what strain will it be. But we do know from past experience that all pandemic strains have been influenza type A. And so that's what these medications are effective against.
So this is not money that we're setting aside in a trust fund. I mean, we're actually going to purchase this product that in a few years may or may not even work for the strain that we have.
Well, I can say that the particular enzyme that these medications work against has continued as long as they've been studying these viruses. So that always is an essential component of the virus.
If I may, I think what we need to do for the members of the committee, because several people have come up to me with this same statement, to make a clarification. Now, correct me if I'm wrong when I say this, but this is my understanding. We're not talking about a vaccine that we're purchasing.
That's correct.
We're talking about antiviral medication, which is kind of another term for it's kind of a broad spectrum type medication used to focus in on defeating viruses, much like an antibiotic would work with a bacteria.
That's correct.
Obviously, it's much different. And this is not, this particular medicine, whether it's Tamiflu or Relenza, is not tied to any particular form of flu, or for that, I guess that matter, any particular, it supposedly can be used for any kind of virus.
It's particularly effective against influenza virus because of that enzyme that I was talking about.
So what we hope is that this particular drug keeps the virus at bay until we can identify the specific strain to hopefully.
No, let me be a little clearer then. I'm sorry. This medication would be used to treat people who are ill. We will have by that time already identified what the strain is, and while we're working on that, the laboratories that manufacture vaccines are going to be working like crazy to make vaccines. And simultaneously, there's going to be a substantial speed up in the arrival of new vaccines. And so we think that in 10 years, HHS is guesstimating that the investments they've made in the development of the vaccine system, that we will then have a very compressed time period when vaccines will be available.
So the vaccine or the drug is given to us by the federal government and is stored locally? I know there's money in the budget for storage fees.
Yes.
All the doses will be stored.
That's correct. They'll be stored here in Georgia.
Somewhere in Georgia to be.
Right.
Do you know, last question, what is the price per dose?
It's in excess of it's about $25, $27 per dose. Or course, I should say.
Next question is from Representative Reese.
So real quick, again, being on the study committee this past summer, we were pretty much told that it will not be the federal government coming to bail us out of this crisis if it happens, or even the state government necessarily. But it will be up to local communities to help educate people. Are we doing anything as far as public awareness in case a pandemic does break out in Georgia? Because with all the chickens and other
Right.
stuff we have around.
Right.
Well, I mean,
No, that's right.
I mean, we could be a very huge target.
Oh,
It was pretty scary listening to all the testimony.
Right. We are a perfect target. You're exactly right. All we need is a wildfowl flying overhead and passing by, and all of a sudden we may very well have a problem. Let me just say that we've been working fairly substantially. We've now got in excess of 150 local pandemic planning groups, and we've got a state planning group that's trying to look at the major issues that remain to be solved and to be decided on. We have not yet developed our mass public education information, but that will be in this next 6 months or so, because we've got to get that information in people's hands so they're aware of what the issues are. But that's, in part, we wanted to get the planning committees up and running and thinking about it, because they're going to be the people who are going to be most knowledgeable in their community, and they're going to help. I mean, I can stand on the TV and say, well, you be careful and wash your hands, or whatever it is that I might say. But it really will be important to have people who are in the community and who are known by folks and who can talk straight about this is what we need to do.
Well, we like straight talk. Representative May.
Thank you, Mr. Chairman. Just one follow-up now. Is this something that's relatively new to us, or did we have this same problem 10 years ago or 15 years ago, and did we prepare for it then as we're trying to prepare for it now?
Hypothetically, we had the same problem forever. It is an issue that we're just now beginning to realize that we actually could do something about it. We don't have to wait for the state to be depopulated. We don't have to have the hospital system get overwhelmed. We don't have to have a passive approach to this. We can be more planful and be more active about it. And so that's the change that's occurred. Plus, there's been a substantial amount of funding that has come from the federal government to facilitate this, to allow us to begin doing some of these things.
Why is this so much on our radar screen now than it was back then?
Oh, it's been on our radar screen probably for at least the last 10 years. But
now
nobody
it's
could,
emergency, or it's...
yeah, nobody could get any real traction around it. And then 9/11 occurred, and we began to say, oh, my goodness, we need to have some thoughts about how we're going to prepare for things. We need to be planful about it. And then the avian influenza began in Southeast Asia, and many have just been kind of waiting, terrified for this to make the leap to human beings. Fortunately, it hasn't.
So if a terrorist organization, for instance, planted some virus in Marta or wherever, I mean, this might not even work to help the people who are sickened by whatever the virus is. Is that correct?
I don't think I understand.
If a terrorist organization, if we're concerned about bioterrorism or anything like that, planted some virus, we don't know that this would even work against that. Is that because isn't that what we're more concerned about, or are we just concerned about avian flu?
We've always been concerned about influenza and the pandemics of influenza. That was what I was trying to respond to. That's been at least a 10-year horizon.
Thank you.
This is very similar to like Spanish flu and some other
Exactly.
very big outbreaks that happened over the last several hundred years that killed hundreds of thousands of people. And it's like almost like a recurrent cycle. So this is not a new thing. It's actually an old thing. We've just learned a lot more about it. It's strange that when mutated for now, you could actually be from animals to people and then from people to people.
Right. And we now have opportunities that we didn't have before. I mean, antivirals didn't exist, essentially.
To close this out, just for my understanding and the understanding of the committee, when it comes to drugs like Tamiflu, my understanding that they're only truly effective if you get them to the affected person within there's a very small window of opportunity for this drug to have any, effectiveness. Is that
Right.
correct?
That's correct.
What kind of window are we talking about?
Well, the shorter the better. Okay, so within 3 days of the onset of illness. And so pardon?
About 36 hours.
3 days, 72 hours. And so what part of our messaging will be is to make sure that we've got the practitioner side looped in, that we've got a distribution system for them, and that we have also the distribution system that we're already planning in the event of any bioterrorist event. Okay.
Would you be willing to kind of go on record? Do you think that an antiviral such as Tamiflu or Linza, do you think that's the best way to go? Let's say this.
No, it's not. Let me be absolutely clear. It is not the best way. The best way is a vaccine. The turnaround time for vaccines right now is 9 to 12 months. And so using the current technology for producing vaccine, we're already going to be, the pandemic will be over. And that's part of the investment that HHS has been making, is to develop that new technology that can make vaccine much more quickly than the current system of growing them in eggs. So that is really what I'm after. And that's why I'm not as concerned about the 10-year window as I might otherwise be, because with a 10-year window, my expectation is that the technology will be dramatically different than it is today.
It almost sounds like we're building a concrete block wall on the beach to stop the tide.
You're welcome.
Thank you.
I'm sorry, I did throw a light on Representative May has one more. I think we're going to use it as 3.
I just have one. Do we have the distribution system in place to get the drugs out?
Yes, we do. That's part of what we've been investing since 9/11, is to build that infrastructure and make sure we're working now on a plan to figure out if anthrax were sprayed through the air in Georgia, in downtown Atlanta, how would we get medication into every individual within a 48-hour time period? And we haven't fixed it. We haven't figured all the details out, but we have a very good core plan for how we're going to do that. And we're working with some key business leaders to help us with some of the logistics and thought processes and the manpower in order to pull that off.
So if with the avian flu outbreak, for instance, we have the ability to get this drug to the far reaches of Georgia.
Absolutely.
In a specified time frame.
Yeah.
If there's no other questions, this item, I think, went to the final item, which has to do with the newborn screening issue.
Yes, the governor's budget is recommending $830,000 plus to replace lost fees for the newborn screening initiative. Basically, what this is about is, in our original budget proposal, we had proposed to begin the newborn screening in July. As part of the budget process, date was moved to January 1st. When we initiate the newborn screening, fees are charged. Because we are now 6 months, only doing 6 months of the program and not the whole 12, we lost the projected fees that we would have drawn in between July and the end of December. And so we are asking for those dollars to be put back in our budget so that we'd be made whole. We continue to operate the old program because in the appropriations bill, it was designated that we would not begin the newborn screening until January 1st of 2007, which we just began. So that's the difference here.
One question on that now. Are we currently, we changed the newborn screening, right? I mean, we're doing a different set of criteria now, right?
We've increased the number of disorders that we screen for.
Now, is that what took place starting January 1st, or did you go ahead and start doing the new screening procedures back in July?
No, that took place January 1st.
So these lost fees, are these for screens that you have already done?
These would have been, why don't you explain?
I guess I'm trying to figure out, when you said these would have been, I'm wondering whether we're talking about monies that we would have collected had we done the screenings, or?
Yes, that's exactly it.
That's exactly right.
Because our budget projection included that, and we did not get the start date, and then we were fixed in that budget projection that we'd made earlier.
Okay.
Because we didn't charge fees for newborn screening until January 1st, correct? Right, so we never charged fees for the old newborn screening. But in order to implement this expansion, we proposed a fee that would be collected, which would help offset and help us fund the expansion of the disorders. And that started January 1st. So before then, we never charged fees.
So okay, and I'm going to make the assumption that you made the assumption when you presented your request for 07
Yes.
that you were going to be able to charge starting in July.
Yes, sir.
Okay, that's starting to make a little bit more sense. All right, we have any questions on this item from the committee? Representative May?
Thank you, Mr. Chairman. How much are the fees, for one thing?
It's $40.
Okay, $40. And so we performed the services but didn't charge the fees? Or we never performed the services?
We never had the expanded cast of tests that we're performing now.
So we didn't perform the services, so why do we need the money for a service that wasn't performed? Maybe I'm just not understanding. If we didn't perform the service, then...
Here's how, we've always done newborn screening, at least over the last few years.
Right, I understand that.
Right.
It's a great idea, by the way.
But it was only for how many disorders?
It was for
Yeah.
It was for 11 disorders.
So for 11 disorders, and we did it free. It was no charge.
Right.
In order to...
We expanded, Chairman Manning had presented a
Yeah.
bill, we passed a great bill, covers a lot more.
That's right.
The thing is, if we didn't perform the service, then why are we charging, why do we need the money for a service we didn't perform? I don't understand.
Why do we need the $830,000?
If we didn't perform
Because
the
in our original budget request that went through the governor's hands and came to the legislature, we assumed we were going to start the new service back in July. And so we would have had 6 months' worth of fees equal to this $830,000 that we would have collected. But the appropriations bill had us start the program January 1st, and so for 6 months we were still doing our old service, the old service.
Right.
And we only added the new disorders January 1.
Okay.
So we are trying, but our budget proposal had projected $830,000.
But I'm still not, I mean,
But part of that analysis also removed the state dollars from our budget. So since we didn't start on July 1, those dollars were gone. So this is to replace those lost dollars.
so the dollars for the services that we had performed prior to that for free,
No. For the new test.
Right.
For the new test, we were going to start on July 1. So what we did was replace the state dollars with fee dollars.
right?
So those state dollars were removed from the budget. But when they moved the start date 6 months, those state dollars were still gone, but we were still operating, and this is to replace those lost state dollars in the state budget, because we're still operating as normal right now.
So the dollars that would have been charged,
The dollars to take care of the current program
right?
was moved out of the budget. A percentage was reduced from the budget. You want to try?
Ellen Williams with the March of Dimes, and we supported this last year. The governor, in the budget proposal last year to the General Assembly, with companion legislation initiating the fee for the first time, proposed that this program start on July 1.
Right.
As a compromise, and prior to the fees being collected, this was all funded by state dollars.
Exactly.
They were going to cut all the state dollars out that had been funding it, use the fees
Effective July 1.
to fund that, right. However, as a compromise with the hospitals last year, they had concerns about their insureds.
If the monies, if we thought we were going to start collecting in July, and you say it was moved back to January, correct?
Right. We were supposed to start July 1.
Wouldn't that money have been appropriated the year prior?
No, it was
No.
moved forward to January.
It was moved forward to January.
Forward
Right.
to
Okay.
I'm
so
sorry,
the
yeah.
money okay. So it was moved
Forward to this January 1 so that hospitals could negotiate with their insurance companies about getting reimbursed for that fee, because they felt like starting at last July 1 was too close a time period for them to negotiate with hospitals to get reimbursed for the $40 fee.
So all of that money for the 11 was taken out.
Right.
All right. I think that's our last item.
We're going to have a few of those every once in a while. So,
But we have them.
but I think we understand what happened now, but it is quite confusing when you kind of
I know.
say for collecting fees for services that weren't performed. It sounds kind of
Yes, it does.
strange.
It does. It does.
But services were performed. It wasn't a specific one that we're talking about.
That's right. That's right.
And we
That's
were
right.
taking the fees out because we were assuming that we were going to be collecting fees and doing a new service.
That's right. That's right. That's
Makes
it.
perfect sense.
I wish I could have said it like that.
That's what I'm here for.
All right.
Okay, at this point, if any of the members have any other questions, I know I do have a question real quick. Well, nothing's real quick, I don't think, in this business. That I would also like to ask that does deal with the 07 budget, but it has nothing to do with your request. It has more to do with concerns.
Okay.
I've had several phone calls, several visits in my home county dealing with children's homes.
Yes, sir.
We're talking about stuff that's in the foster care system and whatnot. And these are homes that were set up by in my case, in my community, by my community,
Right.
with a lot of local dollars.
Yes, sir.
And they were set there basically in large part due to urging by the local DFACS office because they needed additional places to place children.
Yes, sir.
And I can speak personally that a lot of blood, sweat, and tears went into a lot of these facilities that were built with local dollars, local donations. And they're all fine facilities that do a very good job.
Mm-hmm.
What my concern is according to not only my facility in my home county, but other facilities I've heard from around the state, there's been a drastic reduction in referrals to these homes. Now, which that leads to the biggest concern. Is Georgia getting so much better, which I hope it is, that we don't need homes anymore because we are having a drastic reduction in kids who are no longer needing foster care because they do have loving homes? Or is this a change in philosophy that we would rather not put them in these homes? And the reason why I bring this up is I'm thinking that it's probably more the latter, and I'm worried that if we're going to get down the road here in a few years, and these homes are going to be closed up, and then we're going to need them. It kind of goes back to that old adage, putting all your eggs in one basket.
Mm-hmm.
I don't think we need to be one basket in this case. I believe you even actually said in an article with the AJC about the mental hospitals, we need a balanced approach.
Yes.
And I'm worried that if we keep going in this direction, we're not going to have a balanced approach. We're going to have just foster homes and no, local shelters. I know that there was a shelter close by my home that already has closed down, so they no longer have another place to go. And that's a deep concern because when you have these homes that have been set up, your department knows how many beds you're dealing with there. If it's set up for 8 beds, you know that I can place 8 people in that home right there. And you can know that year after year after year. However, when it comes to foster homes, I'm willing to bet that number's not quite as static. I would think that probably jumps around a great deal. I mean, you may, in a certain community, you may have 10 homes this year, you may have 18 homes next year, you may have 5 the next year, because people either get in and out of the program. I mean, am I just grabbing that out of the air, or is that, you know?
I'm not sure that the fluctuation is quite that dramatic.
I may be exaggerating, but it's not the same as the others. And I just kind of want an explanation of where we're going with this line of thinking. And I mean, because we, you know, back to our term about community involvement and community-based services. If there's anything that I would call a community-based services, it's these homes, because I know that a lot of people got very involved in building these homes, starting these homes, and a lot of love and interest went in these, and a lot of community involvement went into these. And if we end up having to shut these homes down, and then down the road we need them again, it's going to be real hard to get those people to make the same commitments that they have made to start these homes again.
Let me try to put your questions in context a little bit. The first thing I think is real helpful to know is that in May of 2004, when I first came to Georgia and to the department, we had about 221 child caring institutions. Those are homes in Georgia that are all over the state who have historically helped us take care of children when they come in our care. Since that time, so in 2 years, a little over 2 years, we've gotten to the point where we have 384 such homes. It has been a 60% increase in the number of beds that we have in Georgia in homes for children. That increase, I think you have to lay against the number of children we have, and I think that's what they just put in front of me. Right now, if I remember correctly, we have about 16,000, and I could say the small numbers when I put my glasses on. We have 16,575 children in foster care. However, that's down from 18,400 children in May of 2004. So, at the same time that we've had the 60% increase in the number of children, in the number of agencies and facilities and beds for children, we've had a 2,000 drop in the number of children who are actually in foster care. Now, there's some good progress behind that issue of fewer children in care. We're probably back down to the level of children we had in care in about 2003, but we had an artificial spike in the number of children who had come into care. And to their credit, a lot of the institutions that formed during this 2-year period did that based on this increase, huge increases that we saw in the numbers of children. So that's where we stand today, is some progress in the system. And I'm not going to tell you our system's gotten so good that we don't need institutions, foster homes, and a lot of help from a lot of people. That's not true. But if you ask me if we're better, yes, we're better. And one reflection of that is that fewer children are in foster care, and we're doing a lot of looking at where are these children going, where should they be going, and whether they're in places that are good for them. The real issue is the 60% increase in the number of institutions and facilities and homes. I agree with you, and I've always agreed that many of the shelters who are part of that number of facilities, these are not institutions. These are community-based. The community cares. It's an indication of a community caring about children. And because of that, and because the reality is there, Mary Dean and I elected back in November to send a letter out to every provider, every home, and say, when your board of directors meets, one of us or both of us will come, put our knees under the table, and talk to you about how we can deal with changing realities, because they're changing. And what can we do to help you continue to support and care for children at the same time as we see these changes and as we see this growth? Because to some extent, and I'll show you just by, and I can give it to you, we've seen some loss of children. The children are the yellow line and the money we spend is the red line, but it's not going down like this. This is the amount of money we've been spending since 2005 in homes for children in Georgia. But what is happening is we have so many homes and facilities. Every home and facility has fewer children than it might have had 2 years ago when there were more children and fewer homes. So we've been going out to everyone who invites us, and we sit down and we talk to them about how they might change their business model to be able to continue to work as we change the system and as the realities change. And we sit down and talk to them about perhaps operating half of your beds as shelter beds and half of them as something else. And for every home, it's a different story and a different issue. But we've made ourselves available and responded to invitations to come and talk about how to make this happen. In addition, we've been holding monthly meetings of one sort or another with providers to try to think about how do we transform what has been the level of care system. It is a system that has a bundled rate. It's a per diem rate. And CMS, about 8 months ago, started withholding our Medicaid revenue until we started to talk with them and assured them that by some date certain, we would take that rate and unbundle it so that there would be one rate for room, board, and watchful oversight, and another rate that would pay for therapeutic services because they felt that the bundled rate was leaning too heavily on the Medicaid dollar. So as we've been doing this, we also find ourselves in the situation of needing to respond to CMS. So far, our response has been good enough that they recently sent us $170 million that they were holding back until we came up with a plan that they were agreeable to. They still have, however, $40 million that they're holding back until we get to the end of the row, as my granddaddy used to say. And so that's where we are right now, is a system where we're making slow, steady progress in improving child welfare systems, where gradually, over time, we expect we'll have fewer children. We're always going to have children, but fewer children. And where we have seen a 60% increase in the number of facilities. And what happens is we get calls. We get calls that we've got a facility in our community, we want to get it open, we need it open. So we're responsive to that. But then that facility is now opening in a community where there are other facilities. And so now the local office is working to try to figure out what's the best placement and utilizing the facilities that it has. That's kind of in a broad stroke where we are. We believe that enough good conversations, enough changing of the business practice and the business model will make many facilities still be offering valuable services. They may be to different kinds of services. One of the great needs we have is large sibling groups, and we've talked to several shelters about specializing in large sibling groups because I'd rather place 5 or 6 kids, and we have lots of kids coming in who are in families of 4 and 5 and 6 children. It's very difficult to find relatives or a foster home where all of them can be placed together. We want to use shelters for that work, and I've talked to several shelters about specializing in the teenagers is another group. Oftentimes very difficult to find places where teenagers can go, and especially long enough where we can find a good family or home who's going to take them permanently. So we've been having those conversations. We know that there is a big impact out there. We're aware of it. That's why we've tried to make ourselves totally available. Mary Dean and I have given out our personal cell phone numbers for 24/7 access, that if people are concerned or worried about something, or a child's being moved or something's going on that they think is a problem, give us a call. I told them to call Mary first, but give us a call, and we will be there to be responsive and to make sure that we feel like the right work is being done every time a child is either not placed or placed somewhere. So, I know it would be easier if we weren't facing these challenges. It absolutely would be easier, but it's the reality of what we're dealing with, and the growth in the number of providers has been tremendous. I'm not sure. I'll look at Mary to see if she thinks I have something to add.
One more piece for you, one more piece of data, the growth on the Norma's writing in the corner. Those are actually beds.
Well, why don't you all come say it, because this is a little scribble scrabble thing. I don't know what it says.
I have my glasses on. Good afternoon. When the commissioner is talking about growth in the capacity, child caring capacity, one figure that I have here to show you how many more beds, if you will, we have now, or in 06, than we had in 02. For our child placing agencies, our private foster care homes, we moved from 600 in 02 to 2,400 in 06. So the reality is that there has not been a policy change that caused these facilities to lose census. There are fewer children available to be placed. There are more places to put them, so you can only spread them so far. And that's the reality. I was supposed to have attended a shelter meeting this afternoon. There was a board meeting scheduled in Augusta that was changed until tomorrow morning. They got 3 admissions yesterday. I can say to you that that regional director and that county director has been meeting with that shelter director continuously to explain the reality and to say, here are services that we could use from you as we move down the line. But with fewer children and more places, it's tough.
I have some comments to add in just a moment, but I have some questions, but I'm going to let the members go next. Representative Mack.
Thanks.
Thank you, Mr. Chairman. This next part is, do you want me to, this may, well, it's somewhat related, but I can wait a few minutes if you need to.
I'm wondering, I kind of finished one subject and move on to the next.
Okay.
So is it related to this? If you're related to the same thing, we'll move on to the next.
Okay.
Both of we will know that are trying to take care of children. I think every community in this state has a center that they have had community input in order to make this available for their children when they reach a crisis with their parents for one reason or another. It's an emergency crisis. In my community, ours is the Open Gate, and we feel like that shelter just does a magnificent job of bringing kids in when they've run away, or when they've gotten mad, or when they told the mama they hate her, or whatever. But it's an emergency thing. They don't really need foster care. They need a cool down care. They need just a little respite. They need an emergency shelter, which is what my shelter is. My question is the fact that we're not placing children in these emergency type shelters because we have fewer emergencies, or is it because we're trying to make that placement immediately into foster care? And the reason why I make that question up is because of the unbundling problem. My shelter comes to me and says, well, they say it's about unbundling services, and I understand it because that's how you get paid. But when you have watchful oversight to be the reason why the unbundling means you can't place a child in an emergency shelter because that unbundling means you have to have a certified social worker or a certified whatever, and I'm hearing it over and over again, and it's somehow, if you've got one of these emergency shelters, which all of us I'm sure do have, these are our communities that care, and it's very, very hurtful, from my point of view, to go home and say, you know, defense is just doing a fantastic job. And they say, well, they're not placing any kids in our shelters and they're not taking care of our kids. They're sending them over to some foster home in Austell. Well, Austell doesn't marry up, you know? And so I'm sorry to ramble on, but I'm on soapbox about this one. I'm sorry.
And I can appreciate that. First and foremost, if we place, they are in our care. I mean, to be in foster care, to be in the state's custody, doesn't necessarily mean that they are in a foster home. So they could be in an emergency shelter and in our custody. There are several issues that are intertwined that I hear you speaking of. Unbundling has nothing, absolutely nothing to do with the decline in the numbers of children who are going into emergency shelter care. Absolutely nothing. So I want to say that really clearly because there's some sense on the part, and it's being said by some, that it is. It is not. The chief reason is what has been described to you. Fewer children, more places. Now, having heard that kids were being taken out of their communities for foster in lieu of, let's say, a shelter, I asked around for specific examples. Region 1, there was a person, the leader of Region 1, stepped forward and said, yep, I did that. But I haven't heard anyone else say that. Now, I'm going to speak to probably the time when their census was the highest, that period of time where we had kids coming through the front door in large numbers. So anywhere to place them was a welcome place to place them. When you have fewer kids coming into the front door, and now we are looking at our data and we're looking at our placement numbers actually come down like this, to the point that it scares us, and we're going in to look to see what's up. Well, actually, we find that it's a front door activity. Fewer children now are coming into care, and that's going to have an even greater impact. We now have the luxury of saying, what is the optimum placement? And that's the progress that the commissioner spoke to. Saying, what is the best placement as opposed to what is the only placement? If there are family blow-ups and children are not in our custody, I don't think we have the authority to pay for those services. I don't think. Now, there may be some prevention kinds of things out there that we could stretch, but that's normally, when you see our LOC budget, which is what emergency shelters are paid from, those are kids in our custody. So the kinds of situations that you're describing are not our realities. They never were. That was never DFACS's business. If we place a child, that child is in our custody, and that's when we pay. Having fewer children does indeed give us the luxury to decide best placement as opposed to only placement. That best placement probably, and they're not just coming into our custody until the family settles down and we can get the kid back in the home. That's not how we operate. We have this court system over here, and we go through those things, so it's never like a cool down period and you go back. But we should not be taking kids out of their home communities to another community to avoid shelter placement. Nobody has been instructed to do that. And if that's happening, that's the kind where the commissioner said, phone in and let me know. And we'll be out there and we'll do something about it.
Chairman Manning brought up a point that I hadn't got to yet, and now I'm going to, and that does do with the emergency shelters. And of course, obviously, there's other shelters who are going through the same thing across the state, but obviously I'm going to go back home and talk about mine right now. And I can tell you from experience, I can remember back when we started a home out in Carroll County called Live Oaks, emergency shelter, temporary stay home. And the reason why we did this is because our local DFAC's office and the people who work there talked to our sheriff and our judges and whatnot, and told us what a great need they had. We had fundraisers, we had rallies, we had all kind of meetings where we had these workers come by and tell us stories about having to keep kids in the office overnight in a sleeping bag, about having to go get hotel rooms and whatnot. And our community came together, and through a lot of not only just financial, but personal dedication, sacrifice, and we built that emergency shelter. I mean, we even had a lady who actually donated a $500,000 piece of property for us to put it in. I mean, you know, I'm fortunate. I come from a very giving community who loves to get involved. We love our kids. And I tell you right now, it is a deep concern, and this is something we're going to keep a close eye on, because you know, we cannot lose these type of facilities, because they do good work. I mean, and I can tell you, and I have personal knowledge of it. I mean, I just happen, this is not why I jumped on this, because to this man's credit, he has not said one thing to me. And I happen to go to Sunday school with a man who's the house parent in our Alice's house. And I've watched him and how he's helping. I mean, he's raising those children. Now, he's one of those situations you were talking about. He's got a large sibling group, and it's probably the only reason why their doors are still open, because that's all he's got lit, I do believe. But now, the work that he is doing in that home is phenomenal, and the change in those kids is phenomenal. And so, my biggest concern is not so much are we putting kids in this place or in that place. It's about results. I've seen these results. I know what these results are, and they're positive. And so that's why this is such a big deal to me and the other members on this community. It's because, you know, we talk about community involvement. We want things to come together. I mean, the state doesn't have all the solutions to every problem. And you're right. We better not be sending kids out of our communities to some way. And I have heard stories. I had somebody come to me the other day that said that there was a perfect case to go to a emergency shelter, and they sent them to Savannah. I live in Carrollton. There's no easy way to get to Savannah from Carrollton. Trust me, I've tried.
I'm going to be looking for that child, because that is wrong.
Yeah, well, the only reason I brought it up is just to say that I have heard that. I didn't bring it until now until you brought it up, because I'm looking for that child too, and I want a verification on that there, because if that's happening, then we do have a problem.
And that's some of the information we've been giving to providers as we meet with the boards of directors. And everybody is caring. I mean, their hearts are with their organizations. I have yet to meet one that didn't say, we do the very best work. But some of them are accustomed to having children from all over the state, and we have had to explain that those days are gone. No more will your recruitment territory be statewide. We want to keep kids in their community. So when I call the local office and ask about the kid who was sent to Savannah, there better be a very good reason for why they sent a child from your community to Savannah, because we are working too hard to keep kids in the proximity of their familiar surroundings and places that they have bonded to.
Well, I'm hoping that was an exaggeration. We do have some more questions.
Chairman Harvard. Commissioner, you've spoken a couple of times about the number of children being down. This is in the foster care system, I'm assuming?
Yes, sir.
With our population growth, what's the reason that our children, the number of children in our care is going down? We just got better parents?
No. There was a time,
We went from.
well, that's child, yeah, there was a time when if you could see this, the spike of children that came in was artificially high, I believe. We are down, but we're not at lower than we've ever been in the last 4 or 5 years. I think we're probably coming back to a sense of normal patterns of children coming into care and more normal. We had a period of time where our caseload spiked 40% at the front door.
When was this?
2004. When I first came,
Right after the downturn of the economy, did it have an impact on
no, it happened after 2 very, very highly publicized children's deaths. And there was just a time period when you can see the spike from where you sit, I'm sure, that blue line, it went up incredibly. And during that time, we were struggling to try to figure out what was going on, what was happening, trying to bring the system back in a slow, steady way. In other words, to really do the right work, still by every kid in every family. And we're probably now at 16,000, about at around the number of children you might expect for a state of our population at this time to have. But during that same period, a lot of people decided to get into the business of building facilities and opening homes. And so we wound up with this mismatch. I don't expect us to become dramatically so low on the number of children that we won't need quite a few facilities and homes. I also expect us to very much get into the habit of utilizing the shelters for a variety of different purposes, and that's going to allow them to continue to be vital links and parts of what we're doing. Most of our workers, when you talk to them, they love their shelters first and foremost. I mean, because those are the people they did go to, and they went with good intentions and the truth on their lips when they came. They absolutely were staying in hotels overnight and having children and caseworkers sleeping on the floor. That's no longer what we have, but it's just it's an adjustment period. That's exactly what we're going through, is an adjustment period.
all of these other shelters that have popped up? Are we hearing them closing as well? Because the one in Augusta that you spoke of, which I'm somewhat familiar with, it's been around a long time, well established, a lot of community support, a paper supporter, everyone is huge supporters, but it is struggling and probably will vote tomorrow to close the shelter. Are the other ones surviving that have popped up? And if they are, why are they getting the referrals and not one that's been around and has done a tremendous job over the years?
There are programs closing around the state. That's absolutely true. When I sat down and talked with the shelter director in Augusta and the board chair, what I recommended to them was that they sit with the director of that DFACS office and begin to work out a game plan around how they may have to shrink in size some, but begin to work with that director to begin to understand how they could remain a resource during this period of transition. I'm hoping and trusting that that's the conversation that's continuing to go on between them, because it is not our intent to see them close. But anytime you're working with an industry where, and to us, everybody has to look equal. I hope you can appreciate that. In terms of dealing with the child caring institutions, they all, unless there's some reason why they need to close, that's a bad reason, we have to sort of deal with them on an equal keel. And that's what we've been trying to do, is to be fair, to be equitable in our approach, but to offer opportunities, the opportunities we have, not the opportunities we used to have, because those are really not the same. In the past, I think a lot of times everybody was full, and even sometimes they couldn't even take children. And that's just not the reality. But it is our intent, and we have volunteered to work with any and all, and particularly, and I know that expresses a sort of preference, but shelters have a sort of different feel. They were grown out of the community spirit. And we want to try to work with them to keep them as part of our delivery system. But what they used to do totally may have to change. And we're still having that conversation, and I trust we're still having it with him.
You remind me of something I want to ask. The number of children we have in the system today, foster care, is that broken down for those that are in foster care homes and those that are in shelters?
We probably have that number somewhere, and I could give it to you. I can tell you. Well, here, I can maybe give you a rough one because I have the level of care program.
I'd like to have one breakdown over the past 10 years.
Okay. All right. Well, we can give you. Is it just shelters or all facilities?
All facilities and just break it down. I'd like to see what our trend is.
Okay. We can give you a chart going back several years on that.
Also, may I add, I'd like to know the amount of foster homes versus the children who were in foster homes. I'm also not talking about shelters. I'm talking about actual foster parent homes. Any more questions on this particular subject? No, I think we have one more question. Representative May.
Thank you, Mr. Chairman. Commissioner Walker. This next thing is very troubling to me, and hopefully you can clarify any misconceptions that I may have with regard to this particular issue. With regard to fines that we had to pay with just an incredibly large sum of money that we had to pay in fines. And I'm going to try to go through this. We are required, and just please correct me where I'm wrong. I'll do some background to lead up to this.
Okay, sure.
We are required by the U.S. Department of Health and Human Services to meet certain federal guidelines.
Yes.
The 7 outcome areas and the 7 systemic factors, is that in those areas?
Yes.
Okay. And we were required to make some changes because we were not in compliance, or in complete compliance with all of the federal guidelines.
Yes.
And we had a 2-year period in which to comply with the regulations, or to bring our program up to the level of the federal level that was required. And then we had a year after that, and they worked with us to correct these problems, and we still were lacking or insufficient, didn't quite make all the federal requirements the benchmark set by federal regulations.
You're sort of on the edge of it. I mean, in general terms, what you're saying is true. When I talk, I can kind of make it more specific. But I wanted to make sure you know that you're kind of generally true. It's not exact.
And that's why I'm asking you. You can probably clarify a lot of this for me. And the areas in which we were not in compliance were permanency 1, well-being 1, and well-being 3. Is that?
I'll ask Mary because I might not know. That's exactly right.
Okay. First of all, did we have to write a check to the federal government for $4.264 million?
Yes, sir. Yes, sir.
That's a significant.
It is, and it didn't make me happy at all.
Well, and I go back to some of your comments earlier. We were asking for an additional the $9 million in particular, and it's 25.5 total, but an additional $9 million to make us whole and help us put procedures in place. And I look at this and I see that there are procedures in place, and we're not quite to where we need to be to meet the federal regulations. I guess what I'm asking is, and according to the report, we weren't yet, as of June of 2006, in compliance. Are we in compliance yet with the federal regulations?
That's a hard question to give you a simple answer to. Let me try to go back, clarify, and then tell you where I think we are. In 2001, Georgia became one of the first states to go through what the federal government calls the Child and Family Services Review. It's the first time the federal government had set forth a set of standards and outcomes measures about what child welfare systems should look like. As a result of that review, which took place in 2001, Georgia was found out of compliance on some indicators, okay? They developed, the people who were here developed a plan, a program improvement plan, because if you fail the measures, you are required to develop a program improvement plan to outline what you will do to get in compliance.
To alleviate any
problems. Right. At the time, they wrote a program improvement plan to the discouragement of the federal government, and I want to be real clear about this. The ACF very clearly tried to say to us, do not write such a large, comprehensive plan. They wrote a plan with 214 or so action steps. 214. They had between 2002 and September 30th, 2004, to actually do every one of those steps. At the end of September, if those steps, all 214 of them, were not done to the federal government's satisfaction,
September of which year?
2004, then you had fallen out of compliance with your program improvement plan, and that is supposed to trigger a penalty. Okay, now let me say this. I came in May of 2004. Somewhere in mid-June, somebody walked in my office and said to me, here's the 214-item program improvement plan that you have to have done in 3 months. And by the way, we've only done 90 of the 214 things. So.
As of June 2004?
Yes, sir. So I immediately started to pull a group together, and we started trying to work on those items. And we did a lot of them, all of them but 11. During the next year,
Are those 11 completed as of now?
we don't have an opportunity. Once September 30th came and went, I have no opportunity to continue to work on the plan. It's done.
September of 04? Or 05?
Yeah, 04.
Okay.
So once that federal fiscal year ended and October 1 came, nothing I did after that can count toward that plan. So now it's a negotiation about the 11 things. And we went back and forth trying to find things that had been done before September 30th that we were trying to serve up and say, well, maybe this satisfies that item. And we went through a very long period with the federal folks having that discussion. I think finally several of them, they did take safety. We passed safety because they did take some work that we found in some file drawers somewhere and pulled it out and dusted it off and got it and said, this is the work. We finally found the work that was done on this particular indicator. But after a year or so, the Fed said, we're not going to negotiate anymore. We're done. We're just not going to accept it, and so the penalty falls in, and the penalty is $4.2 million, partly because I tried to get them to buy into some of the work that I thought I was finding that had been done on some of the indicators. This I will say to you, if I had been here when we were writing that plan, some of the things that were in the plan really didn't make sense to do. They were not in any way related in my mind. And the feds told me they had tried to get us to not even submit these things, but we insisted.
Are we in federal compliance today?
Well, they don't call it that. We're not in compliance until they come back out again. They will return to Georgia in May of 2007. So in several months, they're going to come back out. We are busily preparing ourselves for when they come out. They will do that review all over again. I want to be clear, how many states have passed the CFSR?
The first one?
Yes. No states passed the first one.
Even after the 2-year time frame?
Nobody is in compliance by having passed the CFSR. There's no state.
Even yet today?
Right up to today. Right?
Right.
Yeah, nobody has passed it. Now they're starting the second round, and they're going to go out to all 50 states again.
So does that mean that every state paid a fine?
No, some PIPs were.
Some people had a 25-item PIP that they did a reasonable program improvement plan. They did all the items on the program improvement plan, and they passed it, and they didn't get a fine.
But isn't the PIP is only designed to bring us into federal compliance, is that correct?
We made up the steps. We made up whatever is in there, and we decided what we thought would bring us in compliance. The feds didn't make them up. We made it up.
Did we think we were that lacking in all those areas that required us?
I think we just decided we wanted to be honest and to give glory and honor to the people who were here at the time. I think in all goodwill, they thought they were writing the sort of penultimate plan to improve Georgia's child welfare system, and they used the PIP opportunity to get everything they thought of in there, with everybody at the table. And what they wound up with was something that may have had lots of good things in it, but sometimes you have to be tactical.
What I'm wondering is, should we expect more fines? That's what I'm asking. If we were currently in federal compliance today.
We can't get in compliance. None of the 50 states who failed their PIPs can get in.
We've met all the steps. We've met the 214 steps.
No, even if we did them, they wouldn't take away the fine.
Right, but I mean, whomever was in charge before came up with the 214 steps, and we got all of them at 11, which is incredible in and of itself. I just wondered if we went ahead and completed those 11 steps, so we could go back to the feds and say, look, this is what we've done.
They won't let us. I tried to ask that.
Don't we now have a period to appeal and to work?
I could have appealed, to be honest with you, but the appeal, if I didn't send the $4.2 million, it's like the IRS. The penalties compound with interest back to the date of the end of the PIP, back to 2004.
We could send the money and also appeal, or we just sent the money?
We sent the money, and I elected not to appeal because the CFSR is coming up again in May. And I thought what I want to do is focus my energies on being prepared for the next round of reviews.
You don't think if they thought we were making a good faith effort to correct those problems, they might be willing to
If I could address some specifics.
I'll let Mary, she's been part of this negotiation.
I'm going to bring my crippled self up and address some of the specifics. Some of those things that were promised cannot be done. Just cannot be done. One of them, case in point, they promised, and it was a wonderful idea had they been able to pull it off. In order to expedite adoptions, we would get the adoption process from Superior Court to Juvenile Court. We got that done in Fulton County, and let me tell you, it works very well. But that means that somebody then past Fulton County had to go and work with every other Superior Court judge and say, why didn't you give that up? It wasn't going to happen.
Address the one specifically, which deals with foster care placement. And then the permanency one requires us to maintain accurate documentation of every placement of a child in foster care. And it says as of June 25th, 2006, this work was not complete.
And what that work, what we said we would do to document were some specific steps that we said we would do. And we couldn't prove to them that the specific steps had been done and by September. And that issue had to do with what our data system said and what really ruffled their feathers was that our data system said one thing, a case read said another thing, and our response in the PIP said, well, now that we're doing this case read and reviewing the data systems, the two answers are coming closer together. So I may have some people in my shop who would tell you that by now there's hardly a differentiation at all. But we had some faulty data there. I mean, there are nuances in there that make no sense. And we had overcommitted, and some of that stuff we couldn't come from under.
Well, because one of the points of the report says that at several points during the 2-year term, ACF agreed to renegotiate numerous aspects of the PIP.
Yes, sir. That's what they informed us. They did.
We were not here, so we didn't get that opportunity.
Yeah.
Because if I had had that opportunity, I would have taken it. But Mary came in
05.
05 and I came in 04, and we didn't get that opportunity.
It was the main, I guess, was one of the things that was the fine level, and should we expect more of that?
Here's, and of course I'm going to bring you my most rose-colored glasses today, but here's what I'm going to say to you. I anticipate as we go through the audit, looking at the data that they have sent us, the data that they have sent us that they will be evaluating will cover never mind, she's thinking. We'll cover about a year and a half ago. There's a time frame that they capture data and sent it to us, so we now have it, and we know what we're being evaluated on. We're doing much better now than we were. They have also increased the standards. Whether we're going to pass the first audit, I doubt. I can tell you that right now. I doubt it. But I can assure you that I'm going to write a PIP that I can pass.
Where did the last question? Where did the money come out of the budget to pay the fine?
Let me speak to that. The way the feds talk about the fine is it is a refund of 4E revenue that the state of Georgia earned. So we were required to go in and pull from our 4E revenue and return a certain percentage or a certain amount to them as part of the penalty. So it's federal money. We get about $70 million a year in federal 4E money. And so we return to them out of last year's federal, the last 2 years, we returned the $4 million to them out of that revenue.
Thank you very much.
Mm-hmm.
Representative Carter.
So what we can take home from this, direct question, direct answer.
Yes, sir.
What we can take home from this is we have learned our lesson. It's not going to happen again.
You bet. We're not writing a PIP we can't pass.
All right, to kind of round this up, I know the evening is getting late, and I appreciate the committee's patience, your patience, the audience's patience. Trust me, I do see you squirming out there. 4E revenue, get my ignorance, but exactly what is that?
Let me have Cliff explain it at the level below revenue. It's money we earn from the feds, but how to explain it?
Let me simplify my question. Actually, let's don't get into so much the schematics of what 4E revenue is, but what does 4E revenue pay for?
That's what I'm going to let him tell you. I asked him that earlier, exactly what were the buckets.
4E revenue is the main federal funding source that supports child welfare services in the state. It has a couple components to it. One of the major components is it helps supports the cost of out-of-home placement for kids in child welfare facilities. So, for example, if I'm paying a foster parent $300 a month for foster care, and if that child is 4E eligible, that's a very complicated discussion that I won't take you through, but if that child is 4E eligible, they'll reimburse me at the federal Medicaid matching rate of 60%, so I would get $180 in federal reimbursement for that $300 foster care cost. Out-of-home placement is one big cost area. They help reimburse a portion of administrative costs, and they also provide a small amount of training costs. But nationally, 4E refers to Title 4E of the Social Security Act, and it's the main federal funding source for child welfare services, and it's a partial reimbursement of allowable expenses. Does that help?
That's what he said to me, too.
Actually, that was less. Actually, the pieces of the puzzle are falling together. Okay. Thank you very much. Well,
you get that, Judy?
You want to follow up on that?
I do think that one question, because it's a match and we sent back $4 million of it, our part of it, the state's part of it, what happened to that?
It's still here.
It's still here. So-
We don't send them state money back.
I understand that.
Yeah. And we're still using it to,
So that's part of the 9 million. Okay.
mhm.
Of course,
So we cut the programs.
I'm assuming there's also a chance that we may not have spent that $4 million anyway? Or is it going to be spent regardless?
It's essentially part of this 9 million.
No, the $9 million is a whole nother set of monies. That $9 million is mental health dollars, and those are all state dollars. Yes, this is in the DFACs, which we don't have anything in the supplemental budget, so we're kind of talking about this.
I think everybody's concerned is you hear so much about how tight money is and whatnot, and all of a sudden $4.2 million just flies out the door. Everybody's going, well, where did that come from? What did we cut? And I think that's the underlying.
Part of what we cut was administrative, because part of the 4E money is administrative, so we tucked our belts in a lot on the administrative side, so some of the dollars came from there. Clearly, some of it has to come from the money we have available to us for out-of-home care, and training. But the good news is we have a lot fewer children in care, so that does have some balance and effect. It was not a cut that we are just walking around comfortably with. That is not happening. Yeah, we've been having to get a pencil, and the guy who has the pencil and the calculators and his head, we've been really having to monitor what we're doing and how we're doing it to get there.
Well, that's all from all members. Again, I appreciate your patience.
Well, thank you.
Appreciate the presentation, and again, I remind everyone that we do have a sign-up sheet for the 2 o'clock meeting on Monday for public input. The cutoff on that will be 10 o'clock on Monday. So if you do want to have input on the 07 budget only, I cannot emphasize that enough. There will be one for the 08 at a later date. So if you show up to do 08, your presentation will be very short. Okay. Thank you very much. This meeting is adjourned.